You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
Dr. Gray, welcome to the Nailed It Ortho Podcast. I am happy to have you on. Been looking forward to having you on for a little while. So welcome to the podcast.
Absolutely. No, thank you so much for having me. I really appreciate the opportunity.
Yeah. And typically what we like to do is we just start off with a couple of questions, just getting to know you a little bit more as a person. And I know we talked briefly at one of the courses where you're instructing us and you're kind of helping us go through different approaches. And, you and I chatted for a little while, but if you could, for our listeners, can you kind of tell us the story of what brought you into the field or the specialty of hand?
Yeah. No, I lost a bet is why I'm here.
Oh, yeah.
So, you never welch on your bets.
There you go.
Honestly, so, I mean, I have sort of a non-traditional, but also super traditional path. I feel like kind of most people go through a couple more steps than I did to get into ortho and hand surgery. I was in a combined undergrad med school program at Brown. And so I got into medical school when I was 17. And so I knew pretty early that that's what I was going to do. And so I found out, early on that ortho was something I was probably interested in. I was a student trainer through some of the off seasons in high school and wanted to do ortho. And then I got into ortho and I was like, what's hard? Like hands hard. So I was like, all right, well, let me do that, because I kind of like hard things. And, right. I like outpatient things rather than inpatient things. I like, dealing with everybody, not just old people, not just kids. And so hand sort of has that. It's hard, it's outpatient, and you deal with everybody. So I like that variety.
Yeah. That's what a lot of, you had some guests on and asked some somewhat similar questions. And a lot of people are saying, you can deal with a variety of things. So you can see everybody, it's a wide breadth of things that you can do in the field of hand. So those that are listening that are contemplating hand, there is yet some more, something that helps sway you that way. But next question I have for you is, I know you spent I just reading on you, I know you spent a little bit of time in Florida and then you moved to your practice now. Can you kind of talk about if it was, or I guess the difference between more academic side of being in a job and then more kind of the private academic side of things and kind of your experience with it?
Sure. No, absolutely. Yeah. So my first job out of fellowship was at University of Miami. And I was actually just hanging out with one of my former partners a couple of days ago. I love UM. I loved my partners. But it was definitely kind of academic medicine, big county hospital. DEX, and for those of you who don't know, is like level 0 trauma. It's really crazy trauma. All the things that you see, tertiary, quaternary kind of care. And so that's got its ups and downs. Then we're from the Chicago area, my wife and I originally, even though I grew up mostly in DC. And she was pregnant with our first kid and said, we got to go back to Chicago. So I said, okay, because that's what you do. And so we were looking around, and I ended up coming into it's an employed job with a hospital system called North Shore. And so now we're the North Shore Orthopedic Institute. We have an all ortho hospital, which is kind of interesting. It really functions more like a private practice than academic practice, though I am still academic. I've got fellows and residents from University of Chicago and residents from University of Illinois. And I actually do more teaching and research now than I did when I was at University of Miami in full-time academic practice.
Oh, wow.
But essentially, what are the differences? I mean, really, private practice and academics are more similar than they are different. You wake up in the morning, you see your patients, you do surgeries, you go home. The details of whether you are a W-2 employee or a 1099 employee can vary. Some of the tax considerations vary. Your control over your direct life varies a little bit. The more employed you are, the less control you have, but also the less control you need. If you're in private practice or certainly solo practice, you have all the control, but you need it. You have to order the Band-Aids, you have to buy the staples, you have to buy the printer paper, you have to hire and fire everyone, administrate their 401k, all those things. When you're employed, whether in academics or hospital, you don't have to do any of that. You also can't do that. I can't pick different pens. I can't pick different Band-Aids. It is harder for me to personally hire and fire people. But if you're lucky enough to work with a good team, then, you're able to give up some of that control. And I'm basically giving up some of that control in exchange for some of my free time back. And so that's the choice I've made. Okay,
cool. Yeah. I always think it's interesting to kind of hear everybody's perspectives on their different types of practice. And because, we talk a lot about medicine and orthopedics, so we don't talk as much about, practice and things of that sort. So I appreciate you for answering that. And the last question that we have is, do you have any interests outside of the field of orthopedics?
No, but I'm working on it.
There we go.
I realize I'm like, I don't really have a hobby. I try to work out, that sort of stuff and running. And I realize, well, I'm not going to be able to bench what I'm benching and run what I'm running in another 30 years. So I got to figure out something I can do in 30 years. So I'm trying to teach myself how to play tennis. Try and teach myself a little bit about car repair, though I'd never been interested in that before. Yeah. Basically, I'm trying to figure out like what life skills I think my boys should have that I don't have. And I figure we can learn together. I just need to be like 2 weeks ahead of them, and then we're good.
Yeah, I like that. That's it's always good to find new things that interest you. And, there's a whole world of stuff out there that you can, I guess, just like you said, get skills and learn something else, always kind of evolving and trying to make ourselves better. But, kind of switching gears, and, now we're going to talk a little bit more hand topics today. We can talk about kind of first CMC arthritis, basal thumb arthritis. I've seen many different names of it, but, arthritis of the first metacarpal joint. And just, kind of starting off, what kind of patients do you normally see like with this? Like, I guess, is there a particular demographic or that comes into your clinic? Are they typically male, female? Just getting a little background on it.
Yeah, it's very common in people with hands.
Yes.
Yeah. No, I mean, it really, it just, so it's important. The thing that makes humans really is the opposable thumb. And really the crux of the opposable thumb is the CMC joint. I mean, that's really what allows that motion and enables the opposition, both with power pinch and power grip. I mean, so really it's an unbelievably important joint. And it starts to wear out really early. In men, it starts to wear out in our 40s, and in women, typically in their 30s is when it begins. You see it everywhere, and you'll see it on X-ray literally in every human older than about 40. Symptomatically, it tends to affect women more than men. I'd say probably 50s, 60s is a sweet spot for women, and then for men more 60s, 70s. Okay. Usually once you get to the 80s, it's kind of burned out enough that they aren't coming in for care for it. But yeah, that's who you typically see.
Now, just a thought that I had, I just wonder, given this is off script or did like a not a necessarily a question point, but I was wondering, with the new age of everybody texting, if they'll see an increase in CMC arthritis, in the next 20, 30 years. I always just wonder that. I just assume.
No, it's a great question. CMC arthritis, I don't think so. But for those Thundercats of you out there who are interested in device development like I am, if you want to skate to where the puck is going, it's thumb IP joint arthritis. Because that's what really wears out with texting. And we have no joint replacements for the thumb IP joint right now. It's basically live with it or fuse it. And you can do very heavy activities with a fused thumb IP joint. You can do power grip, you can do pinch, you can sew. It's hard to text with a fused IP joint. It is. So, Thundercats, get your pencils ready, start coming up with your diagrams for your thumb IP joint arthroplasties, and then we can talk.
I'm loving it. And so, I know you mentioned a little bit about the first CMC joint. Can you kind of talk to us a little bit more about the anatomy, like the important things we need to know, like the bony architecture, and then I know there's some important ligaments and everything as well.
Yeah. So this is one of these joints that's studied almost as much as the ACL. There's like 4,000 anatomy papers on it. And I think that, when you have that many anatomy papers on something, even though the topic may be important, the papers may not be as important. But the concept, the shape of it is a little goofy. It's really, I don't eat carbs anymore, but when I ate carbs, I really enjoyed Pringles. And so it's like stacked Pringles. They call it a biconcave joint, or two saddles, and they kind of fit on top of one another, and it allows for a little slop, with rotation and definitely flexion extension in multiple planes. But there's enough congruence in the joint that when you load with power grip, which is really the thing that wants to try to dislocate that thumb metacarpal, that it stays in place. Back when I was in your place taking the quiz, I don't know if they've changed the answer yet, but the answer on the quiz used to be, what was the first ligament to wear out? They talked about the volar beak ligament, the anterior oblique ligament, they like to call it too, many, many names. And that's the one that resists the force. And when that wears out, you start to go into arthritis. Now, someone told me a long time ago when I was in training that the questions never change. It's only the answers that do. Yeah. And so I've seen some things where on some of at least the hand surgery things, they've changed the answer on this. I don't know about for the ortho in training, but really now the answer seems to be the dorsal ligaments. And this is something I thought as a resident, because it just never made sense to me. When you're doing one of these surgeries, you're going to do a trapeziectomy, you go in, you open up the dorsal ligaments. That's super easy. They just fall off the bone, and you're trying to pull that trapezium out, and pulling it off those ligaments is murder. I mean, that's the whole case, is trying to get that trapezium or the crumbs of it off of those ligaments. So I'm like, well, if these ligaments are the first ones to go, why is this the hardest part to detach from this bone I'm pulling out? Never really made sense to me. So while sometimes laxity of that can be an issue, especially in young people with early arthritis, and reconstructions of that, like the Pellegrini reconstruction, are indicated sometimes. I mean, really, I think it's the dorsal ligament that's most important.
And this dorsal ligament is just a ligament that just spans the fourth metacarpal and the trapezium.
Correct. Yeah. And so there's a central part of it, and then there's a radial and ulnar component. And, when you look at the line drawings, it looks a little bit more well-defined. Like anything else, it's easier to see from the inside than the outside. So if you're looking at the joint capsule from the outside, making sense of where one ends and the other begins, it's very hard. Once you've opened it from the inside, you can see it better. But yeah, the straight dorsal ligament, with the radial and ulnar portions, that seems to be the most important in resisting that straight dorsal. And in this point, I mean dorsal with respect to the thumb metacarpal itself, dorsal translation of the metacarpal on the trapezium, which really seems to be the thing that wears out the first and lands you in trouble with your heavy power grip.
Okay. So one thing I like the stacked Pringles analogy when you were talking about the kind of the saddle joint for the trapezium and the first metacarpal. I like that. I took notes and wrote that down there. And every time, at least the couple articles I read, a lot of them talked about that anterior oblique ligament being an important ligament. But I think it's also good to know about that dorsal ligament that you're referring to, and and how you get laxity in that, and then that could end up increasing your load in the joint, leading to some cartilage loss and maybe some back to arthritis and where we're at now, and just like you're saying, kind of that pinch is one of the most important movements, I guess, with our thumb. And so when you see these patients, or when they come to your clinic, what is your conversation like when we're trying to assess where this pain is coming from? Like what kind of conversation are you having with them in your clinic to get to this diagnosis?
Like most diagnoses, this is made off of history almost entirely. Your exam and your images help confirm the issue and exclude other kind of red herrings. But someone comes in and they look my age or older, and there's like if they say thumb or wrist, and they start to point towards their thumb, I mean, it's thumb arthritis, period. That's just what it is. So it's not. Arthritis is very rarely a difficult diagnosis to make. The nuances of it are, well, so you got thumb arthritis, great. That means you're a human and you're not 20. So what do we do about it is the question, and so
Right.
I mean, and quite frankly, I mean, this gets to a larger discussion of what arthritis is and what our treatments are. And you can apply them to the CMC joint, you can apply them to anything. But, I think a lot of times we treat arthritis and we don't really know what we're treating or why we're treating it. So, I mean, if you don't mind, I'm going to turn it towards you. I'm going to ask you a couple questions. If that's
Okay, let's do it. The reverse Uno card.
Yeah, exactly. So arthritis, right? Sometimes we do surgery on arthritis. Why do we operate on arthritis?
Well, I think it is. I think like you were talking about the hip, because you're having a painful arthritic surface. It's a pain generator. So I believe the reason we operate on it is to give these patients, better function, better mobility. I think those are at the core, some of the big things that you want to allow the joint to function and allow it to move how it should, before all these arthritic changes.
For sure. No, absolutely. And so I mean, like, arthritis hurts, right? Sometimes, not all the time, right? If you x-ray a human skeleton after they turn 40, 50, whatever, you're going to find some arthritic joint somewhere, probably several, right? Fortunately, most joints that are arthritic on x-ray don't hurt, right?
Yeah.
Or they certainly don't hurt all the time, or maybe it hurt for 2 weeks and I took some Tylenol and I forgot about it. But the kind of persistent pain that brings you into the doctor's office, it's actually pretty rare, considering how common arthritic joints are. All joints are going to eventually get arthritic. So, you help people get out of pain. You're not really, the fact that the joint itself is worn out, if they don't have pain, who cares, right? So you do it for symptomatic arthritis, not just arthritis, but symptomatic arthritis, to get them out of pain. And specifically, you're trying to get people out of rest pain, not activity pain.
Okay.
And I think one of the main issues that we mess up as a discipline is we're a victim of our own success. And so, hip arthroplasty, knee arthroplasty are very successful conditions or procedures. People keep coming back with more problems. They say, well, why don't I try a hip replacement? Why don't I try a knee replacement? It works so well for these other cases. And the indications broaden. And unfortunately, I think that's the indications can overbroaden, which is why fully 10% of total knee arthroplasties, perfectly done, no problems, no loosening, no nothing. 10% of those patients aren't that happy with the surgery. And knee replacement is a number 3 surgery in the history of surgery with regards to quality adjusted life years. Total hip is number 1, CABG is number 2. So if the number 3 surgery in the history of surgery still has 10% of patients unhappy, what's going on? Is it because the poly doesn't have vitamin E in it? Is it because the cuts are off? It's like, so we focus a lot on our technical factors, but honestly, I think the issue is we over-indicate them. And not because we're bad people or we're lazy, but because when people fail the easy things, braces, pills, shots, and they keep coming back to the office, well, the only thing I have left is to saw out your knee and replace it with metal and plastic. That's the only thing left. And they say, okay, and you do it. But people are universally much more happy with their arthritis surgery if they have rest pain. If they only have activity pain, I can make activity pain better, but I can't promise you that I'm going to eliminate it. I can essentially eliminate rest pain, though.
So does that mean, like, when you're having these patients in your office, your conversation is now, kind of what is the activity level? When does it actually bother you? And then you try to see if it's something that just bothers when they're sitting there versus something, when they're out playing tennis, for example, that it bothers them then. Do you, just reading on and doing some research and just writing up, getting ready for this, I saw, there is a sector of patients that had first CMC instability that ended up, just from repetitive trauma leading to CMC arthritis. Do you see that in your clinic, or have you seen that, or how common is that? Is that something that you see?
It's a good question. So it exists on radiographs commonly, especially in women. And Jennifer Wolf, who's at University of Chicago, who I work with in the fellowship, has done a lot of very high level research looking at some of the hormones, estrogen, and their effect on ligamentous laxity, which may partially account for the reason that women have a higher rate of symptomatic CMC arthritis than men do. So I definitely do think that there is this hypermobility, joint laxity thing that leads to increased radiographic arthritis. Now, does that lead to increased symptomatic arthritis? I'm not so sure. I think it's a thing that maybe sees you and you don't see it. It's that sort of arthritis via laxity. You'll see it in your Ehlers-Danlos patients. You'll see it in Marfan's patients. You see it in really young women, like late 20s, like you're too young to have arthritis, but you kind of do. Those are the people you see it in. The rest, I don't know that I would really. I think it's unfair to lump it with hypermobility is the cause of it.
And so, I mean, when you see them, what's your physical exam like? What are you in your head? If I'm watching you, or if I'm going through your head and you're about to examine the hand or the wrist or however you do it, how do you do your physical exam for these patients?
Well, the most important thing is you go to where the money is last. I mean, again, I know from the history what's going on, right? So what I want to do is I want to make sure I'm right. So the first thing I do for an examination for thumb arthritis is I go to the radial styloid, because I don't want to get fooled and start going down a arthritis pathway and they got Dequerre veins. Then I look pretty stupid, right? So I go to the radial styloid first. Then I go to the snuff box. Then I'm going to go to the IP joint and the MCP joint and squeeze on those. And typically, if you're trying to figure out if a joint hurts, you squeeze on the collateral ligaments of it. And if that's tender, then it's probably related to the joint, usually arthritis. Then I'm going to kind of stress the MCP to figure out if they don't have some gamekeeper stuff, because you don't want to miss that. Then you look really stupid. But really, the thing is you squeeze at the base of the thumb and the pad, which is usually where they point. And that is the area that is symptomatic. Now, you talk about CMC grind tests and that sort of stuff. I don't do that. That really, really hurts people. I don't usually need to do it. Really, just that squeeze front and back of the CMC joint is good enough. Now, the other thing you want to make sure of, two associated things are FCR tendonitis and STT arthritis. So again, I'll run my finger down the volar scaphoid and over the FCR and push on that and see if they don't have tendonitis from FCR tendonitis. If they do, I'm happy, because I can usually make that go away with a steroid shot. If that doesn't work, you can cut the tendon and they're fine. STT arthritis, you don't want to miss. You'll see it on x-ray all the time, but it's rarely symptomatic. So for that one, you're going to I put my middle finger on the back part of their wrist overlying the STT joint, and I maximally extend and radially deviate their wrist. And if they hurt underneath my middle finger where the STT joint is, then their STT is symptomatic.
Okay. And we have a majority of resident, some fellow and attending listeners, but we do have a small bit of medical student listeners. Can you, what is the FCR and the STT that you're referring to?
Oh, sorry about it.
You're fine.
So the FCR is the flexor carpi radialis tendon that's on the volar or palmar side of the hand, and it helps bend your wrist, flex your wrist like you're doing a wrist curl. You also have the FCU, which does that. So you're allowed to get rid of the FCR tendon if you need it for some other purpose. It's expendable. But basically that tendon goes and does a 45-degree curve, and it drapes right over the front of the CMC joint. And when the CMC joint gets arthritic, you get spurs, they'll kind of irritate and rub on that tendon, and they give people tendonitis. They can actually lead to tendon ruptures sometimes, which is not a problem, but can scare patients if that happens. And the STT joint is the scaphoid trapezoid trapezium joint. And so that's sort of on the other side of the trapezium. So the CMC joint that we're talking about is between the trapezium and the thumb metacarpal. And if you move more proximally closer to the elbow, then that trapezium articulates with both the scaphoid and the trapezoid. And you can get arthritis there as well, which is rarely symptomatic, but can be.
Okay. And so you said, you start off with your palpation, you palpate the radial styloid, you palpate the snuff box, and you go along, distally along the CMC joint and the thumb IP joint. And you also check volarly for any FCR tendonitis, which you can palpate that tendon. And then you also will check for any STT arthritis by palpating right over that joint as well. And So, say you've done your history, the 50-year-old, lady came in, points right towards her first CMC joint. You examine her, she has tenderness right over the first CMC joint. Are you getting any imaging? And if so, what are you getting and what are you looking for?
Yeah, I get radiographs on every single person that comes into my office, period. You don't want to miss something. It's too easy, available, and cheap a test. It gives you too much information to not get it. So I get 3 views, ideally of the thumb. Sometimes, depending on when they come through the call center, they just say my hand hurts, my wrist hurts, and the way they may get hand X-rays instead, which is fine. It's enough for me to make the diagnosis and to make sure that there's not some bony tumor there, right? Which rarely happens, but sometimes happens. And I get those X-rays, and I'm just looking for joint space narrowing, bone spurs, subluxation of the thumb metacarpal dorsally, kind of poking out over the backside of the trapezium. And that's really what I'm looking for on that. I don't need any other advanced imaging or anything like that.
Okay. And, so you're just looking at this to, again, evaluate just for, joint space narrowing, any dorsal subluxation, because we talked a little bit earlier about those dorsal ligaments can be lax. And then, also from, I guess, historical or reading of the apical oblique or that beak ligament can get some laxity. But either way, the metacarpal is sublux a little dorsally when compared to the trapezium. So
exactly.
So that's our AP oblique laterals. Now, just in reading, I saw some other X-rays, and I want to see if you use these. But one was called like the true lateral, I guess, of the hand, or Geta view. Is that something you use, or is that one of the views that you're referring to?
Yeah. So the Geta, if I'm not mistaken, they shoot it. The patient holds their hand kind of in karate chop position, and the beam is shot down from the thumbnail side, the dorsal side of the thumb, down to the plate underneath. And it gives you sort of a really nice view of the metacarpal resting on the trapezium, and you can see how narrow or not that is, and how much it looks like it's sliding out, usually to the radial side. Now, there's another actually called Robert's view, which is not mine, and it's basically the opposite. You have the patient turn their hand so that their thumbnail is resting down on the plate, and the image is shot, the beam is shot down from the palm side. I actually like that view a little bit better. It can be harder. You have to have a fair amount of shoulder mobility in order to get your hand that pronated. And so a lot of the older patients can't quite do that. But I do like that view. I think it's useful, especially when you're looking for osteophytes for surgical planning. But I don't think it's mandatory to make the diagnosis.
Okay. And then one last thing I had found was an Eaton and Little view, but I think that was one of the papers I was reading that talked about CMC instability and arthritis. So do you ever use this view, or is this more you'll get this for instability of the CMC joint to see if there's any, or is this more just like one of the historical papers and one of the things just kind of having your toolbox, this Eaton and Little AP view?
Yeah. So Eaton and Littler is so not to throw stones at my academic colleagues, but this is more of a bow tie test. I mean, this is nice to have on the quiz or something like that. But in real life, I mean, I use the X-rays I have. I never reshoot X-rays unless they are completely abysmal and not diagnostic. It's just not worth it to the patient. Slows up your clinic. It's just not something I can reliably do. I don't feel that I can really reliably figure out instability based on these static X-rays, even when they have pushing the thumbs together. So I don't use this one.
Okay. And are there any classification systems that you use for the CMC arthritis?
Yeah, so the Eaton and Littler one is the one that's most classically used. Like everything else, it's usually 1 to 4. And so the early stages actually they describe for like stage 1, the joint space expands. So rather than seeing any joint space narrowing, you see joint space expansion. And the concept is that in the CMC joint in particular, you get such proliferative synovitis that causes pain, has not yet chewed up the joint enough that you see any destructive changes on X-ray, but you actually see joint space widening. That's stage 1. Stage 2, you see like a little bit of a shift. The thumb is kind of sliding out of the CMC joint just a little bit, not totally, a little narrowing, couple spurs. Stage 3, even more, like more spurs, more joint space narrowing, and cysts. And then joint 4 is like total obliteration of the joint, where there's just no daylight, and so, quite frankly, the stage 4s, you don't need an x-ray to see. You see what we'll call the shoulder deformity. When you look at the hand clinically, that CMC joint is like pushed way out radially. And a lot of times what people come in complaining about most, it's not the pain. It's not that they can't grip. It's not that they can't pinch. It's, doctor, look at this big bump over here on my hand. It's like a bunion. I don't like it. This looks like my mother's hand,
Okay.
And I hear that as a primary complaint 30% of the time.
And I think that's a great way to transition into next is, you mentioned a little bit earlier about, us not necessarily just looking at the x-ray and seeing that there's arthritis, but also seeing, the function, if they have activity related pain or having resting pain. Can you kind of talk about the non-operative treatment of CMC arthritis and what that is and which patients are getting that treatment? For sure.
Well, everybody gets non-op treatment for arthritis in the beginning for every joint, period. It's if arthritis is a problem, you start with non-op, because like we were talking about before, every joint is going to get arthritic on x-ray given enough time, but they're not all symptomatic. And people go through phases where they're symptomatic for a few weeks or even a few months, and then it burns out. And the number of patients that come in with horrible CMC arthritis, and they come in for some completely unrelated problem, and I was like, "Did it hurt over here? Oh, 15 years ago, it really hurt a lot. And I got a couple shots, I got some braces, and then it stopped." And the X-ray is just trash. It just looks awful, and they have no motion, but they don't hurt there anymore. So I could do a surgery on that, but why would I? That's not why they're here. So your goal is to convert as many patients as you can from symptomatic positive arthritis to asymptomatic positive, because I don't care what the x-ray looks like if they don't have pain. So how do you do that? Typical things: bracing of some form. You can make custom ones in therapy. I really like, there's an off-the-shelf one called a Metagrip, designed by a hand therapist. That's super effective. Anti-inflammatories. So that's pills, right? That's topical cream. Voltaren gels over the counter now. Topicals work really well for the hand because the skin and everything is so thin on top of the joints. It can really get down to the joints pretty easily. Other topicals, CBD oil. I got a lot of patients swear by that. Other anti-inflammatory, steroid injections. Then you're looking at occupational therapy. There have been some studies that show that it can help patients with their pain. So I don't offer that as a first line treatment because it's pretty expensive, to be honest with you. But it's safe. And so if the easy things don't work and they want something else, they're not ready for surgery, OT is certainly reasonable. PRP, platelet-rich plasma injections. That has more of a role for hip and knee arthritis at this point because that's where the data is. There's currently no data on hand arthritis. I tell patients, medically, it's the best bargain I've got. I'm taking your own blood out of your body, spinning it down, putting it back in you. It's nearly impossible for me to hurt you with this shot. I may not help you. I may waste your money, but I'm not going to hurt you. And depending on your institution, it's an $800 gamble or a $2,000 gamble or whatever the gamble is. And you tell them the price. And unlike other things that are quote unquote covered by insurance, I can tell you the exact dollar amount with this. For your steroid shot, which is covered, how much am I going to have to pay, doc? I have no idea. I couldn't begin to tell you. I can tell you to the nickel how much you're going to pay for PRP. Right. And it may help and it may not, but we can try it.
And to follow up with that, you saying, first things we're starting, activity modification, bracing, and you mentioned one brace called a Metagrip, which I'll probably look up at some point after we finish up here and see what it is. You mentioned topical analgesics, just, you could probably use the Voltaren gel, the CBD oil. How do you do your injections? I guess for style points, just a personal curiosity. In the clinic, do you just feel for the joint dorsally and aim in with an 18 gauge or 21 gauge needle, or what do you typically do for that?
18 or 21 gauge needle. You're mean. You're mean. Man. So first of all, 25 gauge needles.
Okay,
You don't need to
25.
stick anybody with anything fatter than 25 gauge needle unless they stole money from you. Okay.
Right.
Second, now hand joints are tiny, right? They're hard to get into. So I cheat. I essentially do no blind hand injections because they're hard to do. So I use ultrasound for everything. My small joint injections, carpal tunnel, trigger finger, wrist joint. I don't use it for elbow because if you can't get an elbow with a needle, you need a new job. But putting it where you want to put it in the shoulder, I think ultrasound is super helpful. So for me, I will take the ultrasound transducer and I put it on the straight volar side of the thumb, on the palm side. And so I line up the center point on that with the CMC joint. Then I stick my needle in the dorsal side. So I basically in the midline of the thumb, in the middle, splitting the fingernail, kind of that line. I know somewhere along that line is a CMC joint, and I use the ultrasound to tell me how far up or down the thumb it is, and I stick it in that way.
Okay. All right. So say we have our patient that has gone through, all this non-op treatment. They come back and they're saying, Doc, we tried it all. I even tried the OT, spent a lot of money on it, still having this pain. And now the pain, it's really bothersome when I'm just sitting there, just watching TV, not even doing anything. Can you kind of go over some of the operative treatment options and then, what patients are they indicated in or what, kind of what it is?
Sure. Yeah. So, and you nailed it. It's once they told me they got rest pain. Okay. It's like, now you've bought yourself a surgery if you want one. And again, there's nothing mandatory about it. There's no such thing as too late. This isn't, I understand why sometimes the hip and knee and spine folks are like, well, it's getting bad enough and it's not terrible, but you may want to have this now at 70 rather than at 80 because it's a big surgery and you don't necessarily want to go through it at 80. Valid for a hip replacement, valid for a spinal fusion, not for a thumb arthritis surgery. I could do this biologically, you could be 95. That doesn't matter. So there's no such thing as too late. People get mad when you do the surgery too early. So that's the first thing I tell people. But then what surgery do you do? Well, the books used to say you can do anything you want as long as you don't put in an implant. And with the old implants, I think that's true. I don't think that's currently true. I actually do mostly implants for this condition now. But like everything else, you have options for osteotomy to change the axis of the joint, which actually is probably the best surgery for thumb CMC arthritis, something called a Wilson extension osteotomy. You can do fusions, which I don't like for almost any joint, and especially this joint is a very hard joint to fuse. You can do denervations, which are gaining popularity. I do wrist denervations very often. I do CMC denervations a little bit more commonly now. It's a stopgap surgery. It's important to tell the patient that they work about 80% of the time. And work means they turn your pain down by 70%. And they are temporary. They last 2 to 5 years. Okay. But if again, you're trying to fill this donut hole between non-op treatment and the big arthroplasty option. And some people aren't ready for the big commitment of their arthroplasty surgery for very good reasons. So they want to try that. So that's reasonable. I don't do scopes anymore. Scope debridement and interposition is a well-described treatment. For me, it was 50% of the time. It works every time. When it worked, it was awesome. They did great. They maintained great pinch and grip. I used it on my young, heavy, active people. But the problem is no matter how careful I was making my portals, spreading with a little hemostat, trying to avoid the central branch of the radial nerve, I got horrible neuritis at that nerve about 50% of the time. And it took months and months and months for that to get better. And then it would get better, but it wasn't that much fun. But that's certainly an option. Trapeziectomy is the mainstay of treatment. You remove the trapezium. And then once you remove the trapezium, you can do anything, including nothing. You can just stop. You can pin the thumb metacarpal out into space. You can hold the metacarpal in place with kind of a suture bridge contraption. You can do a tendon reweaving of, and I could probably go over 30 different variations of LRTIs, ways to weave that tendon, Wildby, Thompson, all these other things. Whenever you have that many, I mean, they either all work or none of them work. In this case, they all work. And but you could do something to try to resuspend the thumb metacarpal. And then the last option is implant arthroplasty, and that's the one I do most often now.
Okay, and so I'd like to dive into a couple of those a little bit deeper, not way deep, but just a little bit. So when you're talking about the osteotomy, so the main point of this, can you kind of take us through like kind of the thought process behind the osteotomy and the cut and kind of what we're trying to achieve? And then what patients do you do this for? You know, you always read and you say there are a bunch of different options, but like if you're in a clinic, how do you decide you're going to do this versus that?
Yeah, really. I mean, so in my practice, the osteotomy is for younger patients. So I was actually listening to one of your episodes with Seth Sherman. You've had all my buddies on this show, Garbis and Sherman and Brian Cole and Megan Kadinika. And I'm like, man, now I'm big time.
Here we go. Now we got you on.
but so Seth, was talking about these osteotomies he does about the knee for knee arthritis, and I think it's a very similar point. One of the things that hurts so much about arthritis is you are point loading things that aren't supposed to be point loaded. And so you get the deformity, but it's really, you're changing the mechanical axis with the deformity. So if you can recorrect the mechanical axis, redirect the joint forces, things hurt a lot less. So this Wilson osteotomy, it's a closing wedge extension osteotomy. So it's usually about 30 degrees. You take a pizza pie cut out of the dorsal aspect of the thumb metacarpal and close it down, and you can fix it with pins or screws or plate and screws or whatever. And it works because it redirects the force. What happens when that thumb metacarpal starts to push out dorsally, the more you load the joint with power grip, the more it pushes out dorsally. It kind of, it's a slippery slope. So if I can extend the thumb metacarpal, so now when I load it with heavy grip, it doesn't want to push out the back so much, it doesn't hurt. Okay. It's a hard surgery to do, though, and that's a reason people don't like it. It's very difficult to do.
Okay, and so that makes way more sense. That's the metacarpal, the osteotomy. The arthroscopy you mentioned before when you used to do it. You did your scope, and then you also did a tendon interposition with the arthroscopy, or what did you used to do for that?
I use an off the shelf dermal allograft substitute. And basically you expand one of the portals and you just kind of stuff this thing in there and it starts to spit out at you and stuff it in and spits out. And that's almost as frustrating as everything else, trying to shove this thing in there and get it to stay.
It comes right back out.
And you think and hope it stayed in the joint and not floating out in the soft tissue, but you don't know. But yeah, so that's sort of the concept is you give yourself a little bit more room by shaving off the joint surface of both the metacarpal and the trapezium, and you just stuff this matrix in there to give you a little cushion.
Okay, makes sense. And then you mentioned the trapezial trapezectomy, and I remember the first time I heard of this, I was like, so you just take the bone out, like doesn't the bones won't they shift? Won't the function of the thumb change? But like you just mentioned, you could do many things. You could take the bone out and leave it there. You could pin the first and the second metacarpal. So can you kind of take us through why does this even work? Why is this trapeziectomy? I know you're taking out the arthritic surface, but you would think that maybe, this would now just be unstable and there's just something kind of floating around in the wrist area here. At least that's what I used to think as a very young learner.
Yeah, well, you're not wrong. And I will tell you, whenever you see something and it sounds insane, the first time you hear about it, you're like, that sounds insane, but everyone's on board with this. Write it down in your notebook. Come back to it because everyone will tell you, oh, it's fine. This is the way we've always done it and it works. And then you go, oh, people do it this way and it does work. But the fact that your gut reaction was that sounds crazy means that there's room for improvement, right? Like it is not a normal thing to just, I'm going to take this bone out and throw it in the trash can. What? Yeah, throw it in the trash can. You'll be fine. What? So, joints stop hurting when you fuse them, when you remove the joint. So, you a resection arthroplasty, you take one half of the joint out so there's nothing pushing anymore, so that it stops hurting. Or when you do realignments, so you stop loading the most painful part of it, that's an osteotomy. Or when you do an arthroplasty, and an arthroplasty does a few things. It creates a Charcot joint, right? So it's a neuropathic joint. You can't feel the plastic. can't feel the metal, but it also changes the mechanical axis. And very reasonable, smart surgeons can't necessarily agree on what is the most important part of an arthroplasty. Is it the realignment, or is it the neuropathic Charcot joint you've created, or is it both? But so when you do a trapeziectomy, you're doing a resection. So there's nothing to rub anymore. The thumb metacarpal isn't pushing on anything. So the pain goes away. But you definitely lose grip strength. And you have to warn patients. So your young, heavy laborer patients, it's not a great operation for them. That's why people started advocating fusion for those people, because it maintains strength. But fusion is a lousy operation, because I don't care what anyone tells you, you cannot get your hand flat on the table or on the ground anymore in a push-up position. If you can, it means your fusion didn't work. So, those are those options, which aren't great.
Okay, good. I appreciate you for explaining that. And you mentioned the LRTI. What is that? And then can you kind of take us through? Because just like you're saying, I remember the first time I was, in the hand rotation, we were going to do some stuff with the CMC joint, and I was looking it up, and there are a million and one different techniques of how to do the ligament reconstruction. Can you take us through kind of what it is and how it works, and then the general, I guess, principles of this, since we know there are so many different written techniques out there, but kind of what the general principles are?
Sure. Well, it's a resection arthroplasty at its core. So you heard of a girdle stone for a hip arthritis?
Correct. Yes.
Yeah. So it's a girdle stone of the thumb, right? Have you ever seen a patient with a girdle stone?
I have.
Yeah. They actually do surprisingly well. I mean, they've got a limp, whatever, but they're walking, they're doing okay, and their pain is gone. But it's not, if I gave you a choice between a girdle stone and a total hip for your hip arthritis, you say total hip every day, right?
Correct.
And so trapeziectomy is a girdle stone of the thumb. And so it works, pain goes away. But then in order to help sort of ameliorate some of these concerns about shortening of the thumb, loss of the pinch and grip, people are like, well, maybe if I stuff something in that gap, that'll help act as a cushion and prevent the thumb from coming in. So that's like a tendon interposition. So you can use some off the shelf something. You can take half of the FCR tendon or all the FCR tendon and stuff that in there. And so that can help to act as a cushion. Then the ligament reconstruction. So part of the thing is, well, I want to help resuspend the thumb, and I also want to put something in this space. So LRTI, ligament reconstruction, tendon interposition. And the tendon interposition is stuffing something in there. We call it an anchovy when you wad it up. And the ligament reconstruction, you can take a strip of FCR, you can take part of APL, you can, weave FCR to APL around FCR, drill tunnels through the thumb metacarpal, no drill tunnels. It doesn't really matter. The point is you're trying to pull that thumb up, one, and then stuff something in the space, two. And so that's what, no matter what the technique is, that's what they're designed to try to do.
Ah, okay. And yeah, I remember I used to look, and it would say, you take one half of the FCR, just like you said, you could also be done with the APL or the EPB or the extensor pollicis brevis. So it could be done with any of those, but I like how you just mentioned and reiterate that this is a trapeziectomy, and that we're putting something in there to kind of help restore the length, I guess you could say, or that, help with that power grip, and kind of just put something in that space as well. And one thing I guess you mentioned already, but this was a specific name that I looked at when I was preparing for this, was hematoma distraction arthroplasty. But I think that was not fancy, but it was the appropriate word for when you mentioned earlier we do a trapeziectomy, and then you could just pin the first metacarpal to the second metacarpal. Now, is this something that you do, or do people do this as well as a ligament reconstruction, or is this kind of just in its own, like, you take out the trapezium and you just pin it to the other metacarpal?
Yeah. So great question. So basically, we know that all of those options work no matter how fancy you get. And the complications from this surgery of a trapeziectomy tend to be with the more fancy and the more additional other things you do. The pulling the bone out isn't what gives you the problem. It's like all those other things you do. So Roy Meals was a former editor of Journal of Hand Surgery. He really popularized this. Basically, nature abhors a vacuum. If I pull the bone out and do nothing, I'm worried that the thumb is going to shorten before that space is going to fill in with scar tissue. But if I pin the metacarpals together to kind of, keep the space propped open, I'll bleed in there. That clot will organize, will turn to more of a scar wad. So I'll get more of a firm pillow in there. I pull the wire at 6 weeks, give or take, and then it should have less room to shorten. That's the thought. But the take home is, I don't care what you do. Take the bone out, don't do anything, pen it for 6 weeks, do some ligament reconstruction. At 12 weeks, that space collapses on every single patient.
Okay. And then I guess one of the last things that you mentioned, that you actually were saying that this is something that you do, and that there are a whole like list of options of different implants when I was looking and reading on this. But can you guys go through in general, like what these different implants are and how they are used for CMC arthritis?
Sure. Well, the one family of implants is like, cushions of various types. So either made out of cadaver tendon, made out of silicone, made out of like braided nylon, but something to cushion the CMC joint with or without the trapezium in place. So sometimes people will like do nothing and just stuff something in between the metacarpal and the trapezium. And those typically don't work very well. Then you have the ones where you pull out the trapezium and stuff something in there. And again, those all work fine, really, because the main thing that you had to do is remove the bone. So that's all fine. But then the last type of implant arthroplasty is more like what you're used to from your hip replacements and your knee replacements. Some metal or metal and plastic kind of spacer that both resurfaces and realigns the joint. And so that's the kind I use. I use a hemiarthroplasty that resurfaces the metacarpal side. I leave the trapezium largely alone. And then basically this implant works differently. It's like that Wilson osteotomy we talked about in a box. You saw the bottom of the metacarpal off, and this implant has got a 30-degree osteotomy baked into the implant, and you just stick it down the IM canal of the metacarpal. And so it gives you like a perfect osteotomy every single time. And so that's really what it is. It is an arthroplasty, but it really functions more like an osteotomy.
And like you said, so you leave the trapezium, the trapezium alone. You don't do anything to articular surface in that case, but you do resurface the metacarpal, but trapezium stays as is, and you just apply this implant. And I assume the more proximal portion of the implant is somewhat designed to fit the trapezium if you're leaving it alone.
Exactly. So the things I just take off the bone spurs off the trapezium that would interfere with the implant sitting around it. So sometimes you get these really, really large bone spurs, usually on the volar side. And so you got to kind of cut those off so that the implant, which is, saddle shaped at the bottom, sort of like your Pringle chip, it can fit back over. There's a lip that goes on the volar side that, again, resists that dorsal translation force with power grip. And that's why the implant is stable, so it doesn't dislocate. But they have bipolar implants where you have like a little cup that almost looks like an acetabular component of a hip that screws into the trapezium, and like a little stem that goes in the metacarpal. There's all kinds of different options.
Okay, cool. Well, I think overall, I think there's been a great talk on CMC arthritis. We talked about the anatomy of it. We even talked about the epidemiology before that, the anatomy of it, what to look for on, when we're talking to these patients, how to look for examination. We talked about the x-rays and what you're looking for. We talked about, looking for the dorsal subluxation. We talked about the classification and all these different treatment options, all the way from arthroscopy to hemiarthroplasty of some sort. Is there anything else about first CMC arthritis that you want the listeners to know or take away from this episode?
Only what I said before about indicating the patients. Diagnosing arthritis is idiot work. Anybody can do it. Indicating arthritis surgery is hard. And that really, it doesn't have to do with the imaging. It doesn't have to do with this. It has to do with talking to your patient and seeing what their symptoms are and how bad they are. And that goes for any joint in the body. Indicating the patient is the hard part of arthritis, not the technical aspects of the surgery, not that stuff. I can teach a monkey how to do that.
Right. And at the end of our episodes, or towards the end of our episodes, we typically give, our guests, any, if you have any social media, any way for, our listeners to reach out to you or follow you, whether it be a social media, email, whatever you want, if you want to, totally up to you. Or, they can follow you or anything. So if you do have some, feel free to let the world know.
Yeah, no, absolutely. So I'm accessible, maybe to a fault. I got a website, www.robgraymd.com.
That's a very nice website, by the way. I
Oh,
I like the design of it. It was very sleek. I liked it.
I actually did it myself.
Nice.
But so and then on the, so my Instagram is the same thing, Rob Gray MD, and my Twitter handle is the same thing, at Rob Gray MD.
That's awesome. And then Dr. Gray, you've also been so nice to provide us with kind of the surgical approach video of how to at least do this, or how to approach the joint, which we'll go through. For those of you that are listening, you can feel free to check out the YouTube channel to learn a little bit more and actually see what we're talking about. If you want to stick around and listen in, I think that's great and that's awesome. But let's go ahead and take a look at this. And so, is this your main approach for any CMC work? This is kind of your main approach that you do. Is that correct?
Exactly. Yeah, I do a dorsal approach, whether I'm going to do an implant or a trapeziectomy or a neurectomy. I'm going to do it all through the same incision.
Okay. And what are your landmarks for marking out this incision?
So basically, if you extend the incision in your mind all the way up to the thumbnail, to kind of bisect the thumbnail at the 50-yard line, and then goes all the way down, that line to the radial styloid, and you just center it over the CMC joint. And you make it as long as you need to. Usually it's about 3 to 4 centimeters for an arthroplasty, 2 to 3 centimeters if you're doing a denervation.
Okay. And are you doing this under MAC and some local, or are they like completely out most of the time, or does it depend on the patient?
It depends. I've done it under everything. I've even done these under straight local. When you're doing the trapeziectomy under straight local or the implant under straight local, it's a lot to ask of the patient. I mean, you can get through the surgery, but they're kind of hurting in the recovery area. So for the implants, I usually do a regional block. If I'm doing a denervation, I'll do that under MAC, with just some local.
Okay. All right, cool. So I guess I'll click play here, and then you can kind of just walk us through a little bit about of what's happening here, and we can just go through that.
Sure. So the first thing you're going to look for is you want to find your EPB tendon. That's the lighthouse to the thumb. There's like a little sheath on top of it. And so at this point, the right there. Sensory branch of the radial nerve, we've identified and retracted that with the weedy on both sides. And now I'm opening up this sheath on top of the EPB. And if you stick on top of it, you can spread off both the branches of the sensory branch of the radial nerve and also the radial artery. I'm going to take it proximally and release it completely to the first compartment. And I release the first compartment on every one of these. You don't want to come back and have to do a de Quervain's on these patients later on. Plus, the more you mobilize the tendon, the safer it is. Just the tension on that tendon with a weedy, it can actually rupture the EPB during the course of a case.
Oh, wow. Okay.
Yeah,
so
you just fix it with a stitch, but you don't want it.
So first thing, again, so just to repeat, first thing we did is you went down and sized over the tendon sheath over the extensor pollicis brevis. You release a little of that proximally, and then you release it. Yeah, release it proximally, and the superficial branch of the radial nerve. That's superficial to everything. That's why you're using your scissors to kind of stay underneath that nerve, correct?
Correct. Yeah, you got to really watch out for that nerve. If you ding that nerve and get a neuroma, you're going to be in worse pain than they were from their arthritis. So you just really want to avoid that. And that's, in my practice, what I've seen revising people, the number one cause of failed CMC surgery is SBRN neuroma. It's not impingement. It's not whatever. It's not SCT arthritis. It's SBRN neuroma. Okay.
All right. And, okay, cool. So you see the little tendon, nice yellowish structure, and then you use this whittlers to just, what are we doing? Are we just teasing? Are we just trying to?
Yeah. So now I'm trying to work. So first compartment is EPB and APL. So I got to show APL. APL terminates at the base of the thumb metacarpal. And so when I'm doing my implant arthroplasty, I'm sawing off the base of the metacarpal, I often end up disinserting this a fair degree. But here you can see I'm working on top of APL and kind of showing those fibers and releasing that. And you often will see some of the muscle fibers from the thenars over there, and you can just release those. That's fine. There's no penalty in doing that.
And our APL is this right here.
Exactly.
Correct? That's our APL. And then this up here is our EPB tendon right
Correct.
there. And you're just kind of just freeing up between there. And then our superficial branch of radial nerves is somewhere around over here, if I'm
100%.
If I'm not too mistaken here.
No,
cool.
No, you're perfect. And so we want to work in between those two tendons. So, you release on top of EPB and APL, so you mobilize them. I'm going to pull EPB ulnarly or dorsally, and I'm going to pull APL volarly or radially. I'm going to kind of put that weedy back in there and keep working in that space. And that'll protect me from my sensory branch, the radial nerve, and also the radial artery, which radial artery courses directly on top of the scaphoid. So it's a good way to find it. If you are doing a trapeziectomy, if you got to move the radial artery to get to the bone, stop. You're about to pull out the wrong bone. Don't do that. And it goes dorsal to the trapezium to form that feeder in, passing in through the first dorsal area osseous and princeps pollicis of the thumb.
So let's see here. So this is us you're just, again, developing that interval between the APL and the EPB. And then this is kind of more of the capsule right underneath these two tendons.
Right. And so there's like a little areolar layer with the feeders from the radial artery that go down to the joint capsule and more stout. So now I'm putting the weedy underneath those tendons. And so you want to stay right on top of that. In doing this also, I've taken the nerve branches. So that I've basically done the denervation right here. So branches from SBRN to the joint we took off, and branches from palmar cutaneous branch and median nerve we took off to get down there. Now, by working in this plane, this will help me prevent injury to the radial artery. And I do a capsulectomy. I do sort of an L-shaped capsulectomy, which I just drew out there with the scissors, where I come across the base of the metacarpal and then down on the radial side of the metacarpal, and I flap that back up. That keeps me from, if I come across the capsule a little bit more proximally, I can take out the radial artery to the trapezium, which if I maintain the trapezium is a problem.
And you do an L-shaped capsulotomy kind of like that.
Reversed. So
50-50 chance here.
Yeah. Well, no, believe me, you can spin it a couple other ways. So I do the one limb transverse across the base of the metacarpal. A little bit more distal. And then
then kind of something.
One more. So I basically, I'm telling you,
man,
things are. That's why surgery is hard. I mean, they have this stuff be very confusing pretty easily. So where that little red dot was, make your transverse limb right across there, kind of near the end of that weedy. Yeah, there you go, right there. Transverse across the base of the metacarpal.
There we go. So we got something here. Yeah.
Yeah.
So
and then come proximal along APL.
There it is. There we go. Third time's a charm.
No, well, I'm telling you, you can rotate it 4 different ways. And that's my approach, whether I'm going to do an implant or trapeziectomy. It gives me a really nice capsular flap. I can flap that back down and close the joint up pretty nicely.
Okay. Well, let's continue on here. So now you're actually about to do it.
Still yakking about something. I think I'm taking this areolar tissue off the top.
Okay.
Again, to make sure that I don't that radial artery can sneak up on you as you're coming along the dorsal side of that metacarpal. So if you don't elevate that off, you could definitely get that radial artery, which isn't the end of the world. The hand isn't going to fall off, but you just want to avoid it.
You just rather not.
Exactly. And so now I'm making that transverse cut on the metacarpal. And then now I'm coming down inside of APL.
All right. So this is right where APL used to be.
Exactly.
Behind it. Right.
Exactly. And then I'm going to kind
of teasing that off
exactly.
Of the bone itself.
Exactly. And I drop my knife real flat, real parallel to the bone so I can get all the periosteum up off of it. So you have a nice layer to repair down at the end.
Okay. I like it. Well, And yeah, so this is just kind of finishing to raise the rest of our capsule. And then now we're down to our first CMC joint. And then, we're down to do whatever procedure that, that we need to do, whether it be, implant or, hemiarthroplasty versus trapeziectomy or whatever, tendon ligament reconstruction that, we can all kind of access that with this approach.
Exactly. Yeah. The structures to watch out for: sensory branch of the radial nerve, radial artery. If you watch out for those, everything else will be okay.
Yep. And just to repeat, one of the keys to not injure the radial artery was just raising those full flaps where we know the artery is going to be in it. And so we know we're coming straight off of the bone and that we're not going to, get into the wrong plane and accidentally nick the artery.
Exactly.
Well, again, Dr. Greer, I think this has been great. I really appreciate you taking the time out of your day to come on the podcast and talk some hand and we'll go through and share one of your surgical videos and kind of the approach and spending time to break it down and go through these different approaches and these different how many ways can I draw a capsulectomy in the wrong direction.
Well, the thing is, any of those would have worked. They just weren't the way I did it, right. but all of those would have gotten you there. It really wouldn't have mattered.
Right. Well, again, Dr. Gray, I really appreciate you coming on to the show. For those listening, please tune in and hit the subscribe button and go and leave us a review and let us know how much you enjoyed this episode, listening to it. And also, if you're on YouTube, I hope you like and subscribe to the channel and put a comment in the comment section. And please don't go too rough on me for drawing these capsulectomies the wrong way after you clearly described it the first way. But again, Dr. Gray, really appreciate it.
No, thank you so much. I'm really excited with what you guys are doing. It's fantastic.